Thank you very much. So another talk on pulmonary hypertension. Following IPF, you will see that the concepts are sometimes broadly similar, but we are lucky because we are running a little bit ahead, and we have several useful drugs right now. You will be surprised maybe for some of you to hear that we have 10 drugs approved worldwide for a rare disease affecting about 50% per million inhabitants. So these are my disclosures. And I will, in fact, focus on the conclusions of the World Symposium on Pulmonary Hypertension, which took place a year ago, and which was extremely useful. You may know that we touch base every 5 years since 1998, and this was the 5th World Symposium, the very first one being held at WHO in 1973. So this was in Nice, not very far from Italy. And it was a great symposium which has been published in the Journal of the American College of Cardiology. All the proceedings are available in the JAC. So I did define pulmonary hypertension before. So mean PAP above 25 mm of mercury. And obviously the consequences are right heart failure and death. We have drugs available mostly for group 1 PAH, which is quite important to emphasize. We have no drugs approved for group 3 and only one drug recently approved for group 4, which is, this is really important, a surgical condition until surgery has been proven ineffective or not indicated. So I will really discuss mostly treatment of group 1 pulmonary arterial hypertension, so what was called before primary pulmonary hypertension. So in pulmonary arterial hypertension, we have chronic precapillary elevation in mean pulmonary artery pressure. This is due to progressive structural remodeling of the small pulmonary arteries, and we had a discussion just before on that, and you know that the normal vessels become plugged and remodeled, leading to very, very poorly compliant, highly resistant small pulmonary vessels. Consequences are on the right side of the heart. It's a rare condition. The prevalence is between 15 and 50 per million. The pathophysiology is complex, extremely complex, but we know for sure that there is pulmonary endothelial cell dysfunction, and there are some targetable dysfunctions with targeted therapies. 10 agents have been approved in the last 15 years with an orphan drug status, meaning that all these drugs are extremely protected and expensive. It's good and bad. It's good because there was research. It's quite bad because it puts a lot of pressure on the social security systems with patients costing up to 1 million euro per year. Some of my patients have 1 million euro per year prescription of drugs, which is incredible. Lung and heart-lung transplantation should never be forgotten, same than for idiopathic pulmonary fibrosis. Eligible refractory patients should be urgently seen by a lung transplantation team, and this should never be forgotten. We like to make funny cartoons like that, and the abnormal crosstalk between endothelial cells and smooth muscle cell is extremely simple, but at least we know that some of the mediators produced in excess or not enough by endothelial cells can be targeted with drugs, and this has been extremely useful in recent years. So some historical overview as previously in IPF. This is 1950s, this is today, and from the 1950s to the early 1990s, there were only attempts to treat pulmonary arterial hypertension with vasodilators. And it was usually tested acutely, and some patients by chance were responding to these vasodilators and were treated. These studies were uncontrolled. They were published in the New England, nevertheless, but they were uncontrolled. And it's only in the early 1990s that another vasodilator, but with certainly some anti-remodeling effect, was proven efficacious in pulmonary arterial hypertension, with some pioneers like Tim Higginbotham at Papworth Hospital in Cambridge, Lou Rubin in Baltimore and San Diego, Stuart Rich in Chicago, Gérald Simoneau in France, Nazareno Gallier in Bologna, etc. So the first prostacyclin were used in the early 1990s, and then we had a series of drug discoveries, all targeting abnormal endothelial function with the endothelin receptor antagonists, which failed in IPF, but which were successful in pulmonary arterial hypertension, certainly because endothelin is really important in vascular tone, but less so in fibrosis. And then, of course, PDE5 inhibitors like sildenafil were tested positively in pulmonary arterial hypertension. So we had a series of positive trials, and now we have multiple approved therapies. Together with this really exciting time in the field of pulmonary hypertension, awareness, of course, increased a lot, promoted by drug companies, but also by experts. Referral centers were identified. For example, in France, there is only one central pulmonary vascular center linked to a network of 23 regional centers, but there is only one central referral center. In the UK, it's very limited also. National networks were established. Patient associations are extremely important, extremely active. In the United States, Pulmonary Hypertension Association is certainly as important or maybe more important than academic centers. In Europe, PHA Europe is a bit smaller, but growing quickly. Preclinical research is extremely important. Screening high-risk groups is extremely important because early intervention translates into better outcome. As usual in disease, it's better to intervene early. And we have major disease registries on both sides of the Atlantic promoting interesting research in recent years. In 2008, 2009, we did the proceedings of the Fourth World Symposium, and we published the European Society of Cardiology, European Respiratory Society guidelines. And right now, the proceedings of the World Congress 2013 have been published a few weeks ago, and together with Nazareno Gallier, we chair the ESC-ERS future guidelines, which will be presented at the ERS and ESC next year, not this year, next year. So a lot of research, a lot of excitement. This is a cartoon we published in the New England 10 years ago, and I'm afraid that the pathway are the same. There is no novel pathway to target. However, these pathways have been extremely important. This is a section of a pulmonary artery. This is the endothelial cell in the square, and you have three pathways you can target. You can target these pathways with endothelin receptor antagonists, with PDE5 inhibitors, with prostacyclin, and unfortunately, all the other attempts to target other pathways, I will briefly show you some data on PDTF at the very end of my talk, all the other attempts have failed, which is, I think, a lesson. Many targets may not be useful. Sometimes it's better to focus on some targets. And you will see also later in my talk that the solution may be today to combine early the therapies, although it's very costly. These are all the trials we had in PH, and when you compare IPF with PH, it's really surprising. In IPF, you have very little positive studies, in fact, and in PH, most of them are positive. Certainly, a question of endpoint, a question of reversibility, and a question of luck also. But I think pulmonary arterial hypertension is an advanced disease like IPF. But there is a little room for improvement with vasodilators, which have also a little anti-remodeling effect. So right now, we have sufficient information to provide a recommendation, and this is a task force members of the World Symposium, chaired by Nazareno from Bologna and Anne from Sydney, Australia, with many colleagues from all over the world. And we have recommendation for management of pH. And this is available from the JAC. Of course, these are proceedings. These are not guidelines. They are not grade supported. And now we are doing proper guidelines, which will be certainly very similar, but with some slight differences. I think the first thing important to state is that you need to treat these patients in expert centers. It's not possible to treat that in the community. In some countries, in the United States, for example, some local doctors treat PAH. They don't even do right at cath. And this is a problem because the drugs are expensive and it can be harmful if you expose non-real PAH to PAH drugs. For example, in pulmonary hypertension due to chronic lung disease, the vasodilatory effect may decrease the PaO2 and increase hypoxia in these patients. And they may have better hemodynamics but worse gas exchange. So expert center is important not only to confirm the diagnosis but also to support goal-oriented therapies in these people. Of course, you can propose some broad general recommendations, such as avoid pregnancy. It's very sad, but the patients cannot be pregnant because if they get pregnant, they are very likely to die during the third trimester of pregnancy. You have to immunize these patients against flu, against pneumococcal. They have to avoid strenuous physical activity. They need some social support. Some of them can have supervised exercise training, but it appears too early in the World Symposium guidelines. I think it's impossible to consider exercise training before expert referral. This is a mistake from the proceedings, and we will correct that soon. The general treatments, oral anticoagulants, are maybe useful in idiopathic PH, but possibly harmful in scleroderma with a risk of bleeding. So it's recommended mildly in idiopathic PH. And of course, you give diuretics, oxygen if needed, and digoxin if needed, which is very rarely the case. In the expert center, you will have a right at cath lab where the patients will be diagnosed and tested acutely with vasodilator. Why? Because very few patients are responders to real vasodilators, and they will be long-term survivor with cheap calcium channel blockers. So all patients should be seen in the right at cath room. They should be tested acutely with nitric oxide, for example. And if they decrease their mean PAP by more than 10 millimeter of mercury to reach a value less than 40 with a normal cardiac output, they will be candidates for calcium channel blockers, and they will be treated with diltiazem, nifedipine, which is very cheap. Of course, some patients will respond long-term, others will not. So they have to be regularly followed up. And if they have a sustained response, they will stay on CCB. If they are not, they will be considered as chronic non-responders, and they will be merged with the non-vasoreactive patients. Most patients, 95%, are non-vasoreactive. And they have fixed remodeling of the small pulmonary arteries, and they should be considered for initial therapy with PH-approved drugs. And this is a complex table, but it's quite simple in fact. If the patients are very advanced, functional class 4, meaning that they are bedbound, or they are short of breath for very, very minimum exercise, such as going to the bathroom, etc. So these people, they should be considered for very aggressive therapy, intravenous continuous ibuprofen infusion. Very active, very demanding. You need to insert a line in these people, but they will have benefits in survival. That's the reason why it's a yellow indication. It's considered as the only life improving therapy in severe patients. In class 2 and 3, meaning that they are short of breath for either usual exercise or unusual exercise, you can consider any drug. You can consider ERA, PDE5 inhibitors, or prostacyclin. But the key message is that the patient should have a goal. The therapy is goal-oriented, and if the patient, after a few months, do not meet the predefined goal, they should be considered for combination therapy. So most of the patients will not respond long-term to monotherapy, and I will conclude my talk with a plea for studies analyzing upfront combination therapy in these people. So goals of therapy, extremely important. And we had a full task force on that. And in fact, in the literature, some local centers like Marius Hupper in Hanover proved that goal-oriented therapy translates into better outcome. In Hanover, the treatment goals in the early 2000s were extremely modest. Now they are much more ambitious in Hanover and elsewhere. He wanted Marius to have a patient walking more than 380 meters in 6 minutes, which is very low, a peak VO2 more than 10.4, which is very low, and a peak systolic blood pressure of more than 120 at exercise, which is very low. So it was not ambitious. But when the patients were not, they were treated with first-line ERA, for example. If they were not meeting these predefined goals, they were combined with sildenafil. If they were not meeting the goals, they were triple combined. If not responding IV, if not responding urgent lung transplantation. It's a bit historical. We don't do that anymore. In the most severe patients, we start with that, for example. But nevertheless, it was interesting, and it showed quite nicely that if you compare first-line ERA with goal-oriented therapy versus historical control, he observed a better long-term outcome in his patients. And in the guidelines, the 2009 guidelines, a goal-oriented treatment strategy is recommended, 1C recommendation, quite high, but expert opinion for the level of recommendation. So, in fact, when we see a patient, it's not at all the same thing when you see a 25-year-old lady or 78-year-old scleroderma lady. You cannot have the same goal for everyone, so that we have to tailor treatment goal to the individual, the comorbidities, etiology, age, gender, BMI, etc. What we do right now is we set treatment goals, and these are possible treatment goals, different according to the patient. Then, on treatment, we establish patients' clinical status. If they are stable and satisfactory, we are happy. If they are unstable and deteriorating, we are not happy. If they are in between, we are not happy either, because we know that you have to reach the stable and satisfactory level. And we escalate therapy. In most patients, 65% of patients have escalation after first-line therapy. 1/3 have no change because they meet the predefined goals. These are the recommendations. The patient should be seen at baseline, of course, and then every 3 to 6 months with a series of evaluation. In my center, we are very aggressive. We perform regular right-heart cath because we believe it's the most informative information, but examination. But some people make a combination of non-invasive evaluation. The important thing is to predefine the goals and to have an intervention if the patient do not meet the goal. Sounds like asthma, in fact. These are the current goals, very ambitious, nothing in common with the Hupper paper. We want the patient to be in class 1 or 2. We want the patient to have a normal right ventricular size and function. We want the patients to have a normal right arterial pressure and cardiac index at rest, a near normal 6-minute walk distance, and a peak VO2 above 15. It was 10.4, and a BNP level normal, so less than 100, which is quite ambitious. So today, after initial first-line therapy, the patients have been evaluated after 3 to 4 months of therapy. If they have inadequate clinical response, there is a 1A recommendation for sequential combination therapy, because we have lots of papers published in the New England, in the Lancet, in the Annals of Internal Medicine, showing very clearly that sequential combination therapy is efficacious. And a very important thing, and it will be with the same thing one day for IPF, when a patient does not respond to first-line therapy, not only we consider sequential combination, but we want the patient to be seen by a surgical team if eligible for lung transplantation. Never forget lung transplantation. It's a pity to see end-stage patients while they could be transplanted months before in a better situation. So this is a simple slide. From the 1990s to today, we went from 1 drug, IV epoprostenol, to 10 drugs. We went from extremely complex therapies, IV line, lung transplantation, to very simple therapies, tablets. But have we improved long-term outcome? Not sure. But in fact, yes, but not that much. This is what we observe in France with modern management in the early 2000s, and this is a predicted survival we improved by 15% survival, which is not 10 to 15, which is not bad. Now we are above this curve, so we are doing better, but this condition remains extremely severe. And how to do better? I think there are three major things with what we have, and there are future development. With what we have to treat early. We have to screen for pH at-risk population. We have to treat to target, as I did show you in great detail, and we may have to change strategy. We may have to consider upfront combination therapy, and we have to develop new drugs, but it's a difficult task. So pH is diagnosed very late, usually, because it has a low prevalence. Most people are not aware, so there is low suspicion. It's asymptomatic early. You need to occlude 60% of your vessels to be symptomatic, and the symptoms are non-specific. So the diagnosis is typically delayed by above 2 years. We have now recommendations for screening in some risk population, such as scleroderma, and I'm going to show you very quickly the French screening program. It's an early detection program, it's not a screening program, and the patients were screened by echo, and thanks to the echo screening, we could identify patients who are at risk of having precapillary pulmonary arterial hypertension because they have estimated systolic PAP above 45 or above 35 with symptoms. But of course, we never stop after echo. We do the right heart cath, and the right heart cath will tell us whether or not the patient has precapillary pulmonary arterial hypertension. To make a long story short, at the same time period in 2002, we were able to have routine basis scleroderma pH diagnosis in the French registry and active screening or active early detection in another scleroderma registry. This has been done in parallel, and we were able to compare outcomes. So routine practice, you wait for symptoms, you wait for too long, and the patients are diagnosed very late in the course of the disease with very high mean PAP of 49, very low cardiac index, very high PVR. If you screen, you have lower mean PAP, normal cardiac output, and lower PVR. And the important thing is that with early intervention, you have better long-term outcome with a dreadful survival in routine basis diagnosis and a 64% 8-year survival in screened patients. Of course, it's not a randomized controlled trial. You may have overdiagnosis, you may have length time bias, lead time bias, but it is, I think, a meaningful information. So combination therapy, the current dogma, you have understood it, it's a sequential approach. You start with drug A, if it doesn't work, you combine. So it's based on failure, which is not my style. I think waiting for failure is not my ambition. So the future dogma will certainly be to propose upfront combination therapy. This is very poorly recommended in current proceedings because there is no data. But we published 10 years ago a paper showing that upfront combination therapy with bosentan and epoprostenol achieved slightly better hemodynamic results at 3 months versus monotherapy, but it failed to be significant. The p-value was 0.07. And we have our registry showing that upfront combination therapy in severe patients does slightly better, but once again, the p-value was 0.07. So it was not outstanding. And we have a paper in press. It will come in June in the ERJ with an editorial by the colleague Mike McGoon from the Mayo Clinic on upfront triple combination therapy. So IV epoprostenol, oral PDE5, oral ERA in extremely severe late diagnosis in class 4 in young patients. And what Olivier and the team has showed is that you can achieve marvelous results with this upfront combination therapy in a very highly selected young patient population. I don't say it will work in 80-year-old scleroderma, but I know from my practice that there is a quite clear signal in severe, young, usually BMPR2 mutation carrier population. So this is what we observe with monotherapy, with combination of 2 drugs and with combination of 3 drugs. So, of course, this is only registry data, but there is a flavor of something with upfront combination therapy. We will need randomized control trials. There is one currently comparing ambrisentan ERA first line, tadalafil PDE5 first line, and a combination of the two first line. The FDA requested to have each arm analyzed, so we will know whether drug A, drug B, or drug A plus B is efficacious. And the primary endpoint is no longer 6-minute walk distance. It's time to clinical failure, so a very clinically sound primary endpoint. So this is a pipeline of PH. When you have success, you have a pipeline full of new drugs. But my criticism is that nobody takes risk. You see, prostaglandin are in blue, so there are many prostaglandin, but we have quite a lot of prostaglandin already. ERA are in purple. There are many ERA in development. PDE5 in yellow. We have sufficient number of PDE5 right now. And others are in green, and they are very few, and they are early in the pipeline. So this drug discovery is not really promoting new pathway, but it's rather developing me too of known pathways. So it's my major criticism. And for example, we have tried to develop PDGF blockers, and it will be my last slides. So the IMPRESS study was a nice randomized control trial of imatinib in PAH. The good thing was that patients were doing better in terms of 6-minute walk distance, but we don't care of 6-minute walk distance. What we want is time to clinical worsening or time to clinical failure. And believe me or not, with imatinib, there was more deterioration than with active treatment. So they work better, but they do less well. So I think the take-home message from that is that there were dramatic side effects, such as subdural hematoma. We had sudden death, and it is really a warning signal to people who develop TKIs in any kind of non-oncologic indication. Major problems may occur. So I think I can conclude now with the editorial I wrote in Circulation. I took the Impression Sunrise painting by Monet, and I call my editorial Impression Sunset. I think the Novartis people didn't like me very much after this editorial, but I really think that it was an interesting study, but a negative study. Doesn't mean we should stop on PDGF, but we should take care with side effects. Thank you very much.
Thank you, Professor Humbert, for your excellent state of art concerning pulmonary hypertension treatment, completing your previous lecture. So there is the possibility of a couple of questions. In the meantime, I have a question concerning the problem of systemic sclerosis, or scleroderma, as we prefer to call, because we have two positions in the classification of pulmonary hypertension, because we have the patient that develop isolate pulmonary hypertension, so there is no problem, they are in the first group. But there are the patients that have interstitial lung disease, and sometimes the rheumatologists use antagonists, endothelin receptor antagonists for treating peripheral ulcers in these patients. So they, in this way, can use the very potent, very powerful treatment that is for pulmonary hypertension in patients that probably could have in the future interstitial lung disease, in which we have no indication at the moment. So what do you think about this? It's an intriguing problem.
Yeah, I think it's a complex story. In scleroderma, you can have very pure PAH.
Yes, I know.
And there is no doubt
that is very rare, I must say.
Yeah, but we have quite a lot.
Yes,
so
yes.
They should be treated. They respond less well than the others.
Okay.
Then you have patients with left heart disease, quite common. Patients with pulmonary fibrosis, quite common. And some lazy people do not want to do the right at cath.
In fact.
So they say, well, the patient has 2 ulcers of the fingers.
In fact.
There is a label. So let's try the ERA, but it's a mistake. It doesn't prevent pulmonary hypertension, and of course it prevents recurrent ulcers. But if you think that the patient has pulmonary hypertension and pulmonary fibrosis, you may deteriorate the situation with ERA. So I think they should be seen by expert centers, these people.
So someone thinks that in this way they will change the figure of pulmonary hypertension because they prevent.
Yeah,
so I am not
There is no
convinced.
data showing that you can prevent pulmonary hypertension with
Thank you.
ERA.
Thank
No
you.
data.
So, Professor Fab.
Mark, thank you very much. I'd like to have your comments on a couple of issues. In all the diseases we have been discussing in the past 2 days, and particularly for COPD, there is a continuous debate on the missing early diagnosis. And we know all the issues are related to that. It's anything coming up that may help to get these people early? That's the first question. The second regards the secondary or the hypertension, particularly associated, the few people with COPD that have also. Is any of the algorithms you presented that are more or less valuable in that phenotype?
Thank you. So the first question about early diagnosis. In PAH, either it's idiopathic, it's very difficult to find in the community early patients because shortness of breath in a 45-year-old patient is usually not really investigated in great detail. So I work a lot to say it's not asthma, it's not COPD, it's not heart failure. Please do an echo, and if you don't understand, send unexplained shortness of breath to specialists of pulmonary vascular disease, because you can find CTEPH, you can find idiopathic PH, and we have drugs, in fact, and we have surgery. We have two populations in which more than that, but two major populations in which we have done early detection and screening. That's scleroderma. And there is a paper called DETECT, published very recently in the Annals of Rheumatic Disease, in which a multinational group of investigators performed systematic screening program, and they were able to identify patients very early with a mean PAP of 24, 25 to 26. So this is interesting. The very big mistake they have done, I think it was a funding issue, is that they did not follow the cohort. So it's a big mistake. They identify patients early, but they don't follow them. So the information will miss. While we did a follow-up in the French registry. So I try to motivate them to know what was the intervention and what was the outcome. BMPR2 mutation carriers in France, we have support from the government to perform very invasive screening, because these people may die early, and we do right at CAS in volunteers. So we have done 50 patients, and then we follow them yearly with non-invasive tools. And in 3 to 5 years, we will have information on very early diagnosis. In IPF, I think with the screening of lung cancer, you will have lots of early IPF identified. And I think this is a key issue to investigate for your group of specialists. I think I know there was a paper by Jean-François Cordier in the ERJ, neglected evidence. I think you should work on that.
Thank you very much.